Okay, I think we can start. Dear colleagues, dear friends, good afternoon if you are in Europe, good morning if you are in America, good evening if you are in India. This is Lefteris Tapakis, and on behalf of VithoulkasCompass team, it is with great joy that I welcome you in this webinar series, which has as a theme the improving of the quality of clinical case reports in general, and in particular, the COVID-19 clinical case reports in homeopathy. On the whole, we are going to have 4 webinars, and the 4th webinar will be more interactive, like a workshop. Andreas Tsokanas, also a member of VithoulkasCompass team, is the host of today's webinar. Andreas, please say a welcome word.
Good afternoon. It's a pleasure to be here, and I hope you all enjoy this webinar. Thanks for being here.
Our special guests today is Dr. Robbert van Haselen. I don't see him right now. He will come soon, I hope. And Dr. Chetna Lamba. Hello, Chetna, from India. And thank you for accepting our invitation to join us. Dr. Chetna Lamba has done research and contributed in clinical case reporting in homeopathy. And Dr. Robbert van Haselen as well. Because we have many attendees, the attendees will not have the chance to speak, at least not in this first webinar, but you can write your questions in the Q&A section with to whom you address the question, and we'll try to answer the questions in the end. Our teacher, Professor George Vithoulkas, has been for many years stressing the importance of clinical case reporting and has published numerous case reports. Lately, he received a distinction from the medical journal Clinical Case Reports of Wiley for his case reports being among the top read. Now, please allow me to read a quote that he wrote in his letter to the editor of the Journal of Medicine and Life 3 years ago, with the title An Innovative Proposal for Scientific Alternative Medical Journals. So Professor Vithoulkas writes, the successes of homeopathy have remained hidden in the offices of hard-working homeopaths and thus go largely ignored by the world's medical authorities, governments, and the whole international scientific community. And with this quote, he wants to stress the need to show our work and to announce clinical cases. Now we are going to watch a video from George Vithoulkas' speech, which took place some days ago on the World's Homeopathy Day on the 10th of April to a large audience in the context of webinar organized by CCRH Committee of Ayush. Ayush is the Ministry of Alternative Medicine and Homeopathy in India, and Dr. Chetna Lamba is a member of it. Let us watch a part of his speech. We don't hear, Andreas.
I have seen also is that in all these years of my practice, when people were phoning for a flu symptomatology, we just give a remedy and people were recovering very fast. So I'm I was amazed that at this stage where coronavirus 19 has manifested, why there was almost a global forbid to apply homeopathy in these cases, because the effect of homeopathy could be so effective in the beginning stages of this influenza that a big percentage would not end in the hospitals. And the best that could happen, according to my understanding, is that there may be in the hospital 2 departments, one that receives patients and treating them with conventional medicine, and the other group, conventional medicine, but adding the homeopathic remedy. And this would be a real critical point where everyone could see the difference between those treated with homeopathy and those treated only with conventional medicine. But as I said before, the most effect is in the beginning stages, where homeopathy can stop the development of this disease. I hope that the blessings of Hahnemann will come to all of us that are struggling at this moment to show the effectiveness of this science.
Okay, very nice. We see here that Professor Vithoulkas proposes a model of research that hopefully can be more easily accepted by the established medicine. In this model, homeopathy is proposed as an add-on therapy to conventional medicine. That is, for example, in a hospital, to give to a group of patients homeopathy in addition to the conventional drugs, and compare the onset of this group in relation to another group that takes only conventional drugs. So you have one group that takes conventional medicine plus homeopathy, and another group that takes only conventional medicine, and to compare these 2 groups. The whole speech of Professor Vithoulkas is just 13 minutes, and you can find it in Facebook. We will write in the URL in the chat box in order to see it. Now, at this point, I'm going to present briefly 2 COVID-19 cases. I will share my screen. Okay. This is the first case. It is a young man of 24 years old. Symptoms started 7 days after getting in contact with a colleague of him who had recently traveled to London before he was diagnosed positive for COVID-19. Our patient also is diagnosed with COVID-19. In the beginning, the patient developed recurrent pain in the stomach every 2 to 2.5 hours, and he took arsenicum by himself because he's also a medical student and reading homeopathy as well, but with no result. On the second day, apart from stomach pain, he developed bone pains all over his body, and he was feeling exhausted. His body temperature was steadily elevated to 37.9 Celsius. He had difficulty in breathing and was feeling heaviness on the chest. There was rumbling in the abdomen and distension, and Lycopodium 1M, 3 doses were prescribed every 1 hour. Let us see the symptoms. The doctor gave the remedy on the knowledge of materia medica, and he did then the repertorization. And you see Lycopodium mainly because of distension and rumbling. Now, after Lycopodium, stomach pain got better, but he started suffering from continuous diarrheas. On the second day still, apart from slight stomach pain and diarrheas, he also feeling nauseous. And because of the intense nausea, Ipecacuanha 1M, 2 doses were prescribed, and he got 70, 20 to 80% better. Let us see about the Ipecacuanha, the second remedy, actually the third, because arsenicum in the beginning did not act. Ipecacuanha, the remedy, mainly because of the nausea and the diarrhea, mainly because of the intense nausea. We know Ipecacuanha of this nausea that it has. After Ipecacuanha, the next day, he received China, mainly because of the distension, which was still there and was not ameliorated by Flatus. After China, distension was less, but the area continued, and pain in the stomach and bones were still the same. Let us see first about the China officinalis, mainly because of this keynote of the distension, which is not ameliorated by Flatus. But weakness is still there, and diarrhea is still there after China. And then he was advised to take sulfur. Let us see the last repertorization. Sulfur. The appetite was still low. The pain of the stomach was better, but still there. Rumbling was less, but still there. But mainly he has this diarrhea, and the doctor searched the repertory and found this interesting rubric, diarrhea after acute diseases, and he based his prescription on this symptom because the chest problems were better, but the diarrhea was still there. And 24 hours after sulfur, he was 90, 20 to 100% better, and the appetite got back, and the patient got better. This is a case that was sent to us by Dr. John Lefteris, which is an experienced homeopath here in Greece, a student of George Vithoulkas. This is the first case, a confirmed COVID case, and I have one more case to present to you. This second case is not, we don't have, unfortunately, we don't have yet the test, and we are not sure if it is a confirmed COVID case. So I present it as a suspected COVID-19 case, but I find it interesting because of the reaction it had after the remedy, and also some chest x-rays that we have that showed improvement after the remedy. This is a woman of 51 years old with chronic problem psoriatic arthritis. Her symptoms started some days after 15th of March after experiencing grief for the preparation of a memorial ceremony for the loss of her mother that he lost 1 year ago. And during this ceremony, he came in contact with a lot of people. After some days, the symptoms started, which included extreme weariness. He was finding hard to even walk or climb stairs. He had chest and back pain and pain all over the body, especially the joints. She went to the hospital and she was proposed admission, but she refused. Her husband is a homeopath, not a professional one, but she didn't want to stay in the hospital. She was afraid also. And she chose to take only homeopathic medicine. And on the 21st of March, she raised fever that went up to 28.3 the next day. And the patient also developed very severe headache, intense pain in calves and on the knees, generalized pain in the extremities, general discomfort, cold skin, and she felt almost she would collapse, feels as she's going to die, enter a panic state with prostration. Shortness of breath, interrupted speech, symptoms almost chilliness, symptoms almost looking like hysterical symptoms. But at this point, it is interesting to look also at the X-ray that she had. Let me share the X-ray. No, just a minute. Can you see the X-ray?
No, Lefteris.
Eh?
No.
No. Okay. How about now?
Yeah, much better now.
Okay. This is the X-ray that has this diffusion, this collateration in both lungs, both in the anteroposterior X-ray and also in the profile picture. You see these vessels here. And this X-ray was done on the 13th of March. The remedy was prescribed on the 26th of March, 4 days before, but still this was the picture. And 2 days afterwards, we have a much better X-ray with this picture. And what was also impressive, according to the homeopath, is that after after she took the remedy, the improvement was immediate. This state of collapse and this chilliness got much better immediately, but she needed some repetitions of the dose. The remedy was camphora that was prescribed, 1 m and 10 n, and the homeopath gave some doses, repeated the dose several times. Okay. Now, I'm going to pass the microphone to Dr. Robbert van Haselen. Dr. Robbert van Haselen is the director of the International Institute for Integrated Medicine and the World Integrated Medicine Forum. He has long experience in research in homeopathy and served as an editor-in-chief of the peer-reviewed scientific journal Complementary Therapies in Medicine from 2004 until 2015. He has particularly contributed in elevating the quality of case reporting in homeopathy. Dear Robert, it's an honor to have you with us. And I'm now passing the microphone.
Thank you, Lefteris, for the kind introduction. And let me start by sharing my screen. Can you unshare your screen, Lefteris? Okay, let me just see that. One moment. Can you see my screen?
No, Robert, not yet.
Again?
Not yet.
Something is preventing me from... So maybe someone else is still sharing their screen. Wait a second. How's that?
Okay, you're okay now. We can see your screen.
All right.
You can see your PowerPoint. Okay.
Okay. Yes, so, well, thank you, Lefteris, for your kind introduction. And also I would really like to thank the VithoulkasCompass for facilitating this topic. I have been working on this topic for about 12 years now. Since the last about 7 years, I'm giving seminars and lectures on this topic of improving the quality of clinical case reports. And so it's a real pleasure also at this occasion, and as facilitated by the VithoulkasCompass to share some of my thoughts on this topic. So as a brief overview, I will address the topic of why is it actually important to improve the quality of clinical case reports. Maybe some people may feel that there is no need to improve the quality, that everything is fine. Then, of course, how can we improve the reporting of clinical case reports? And then I'll spend a few minutes also to talk about the topic of critical thinking. That may sound, well, why do we need critical thinking? But I will try to explain, to make the case that we need both in conjunction. We need, on the one hand, guidance on how to properly report clinical cases, but we also need critical thinking to optimally benefit from these case reports. Right. So in my lectures, I often speak about practice-based medicine. Now, we're all familiar with this concept of evidence-based medicine. Now, practice-based medicine is part of evidence-based medicine. But for practice-based medicine, we need a close link between research, education, and practice. Now, what we see in the conventional medical world and also in the homeopathic world, that the link between these three aspects is relatively weak. In other words, practitioners, they tend to think, okay, I'm practicing homeopathy in my clinical practice. I don't really need to do research. Research can be done by smart people in laboratories or whatever, but it's important, but it doesn't really, it's not really relevant for me. And so that is actually a fallacy. And what I will try to demonstrate is that this link between research, education, and practice can and should be very close for homeopaths as well as conventional doctors alike. So when I speak about this practice-based medicine, I always, as a simple metaphor, I'm saying, well, consider that as a chain, and this chain has 4 elements. And I call that then the quality value chain, also using the metaphor that the chain will be as strong as the weakest link. So the first thing, obviously, is what we need is high quality homeopathic medicines. if we have poor quality medicines, we can prescribe the similimum, but it won't have any effect. The second aspect is learning from and collecting good quality cases. That's what we will be talking about today, and that we'll be focusing on in the webinar series. The third one is we need reliable information in materia medica and repertories. And as most of you will know, is that people like Lex Rutten, but also very proactively the VithoulkasCompass, they are really working hard to improve the information in the materia medicas and repertories, and also to improve the information in materia medica and repertories based on our actual practical experience. So good quality cases feed also into, ultimately, if we use that experience to learn from, to feed into the information into the materia medica and repertories. And so this is also part of the broader vision why the VithoulkasCompass team is very keen to promote also the improving the quality of case reports. And the fourth element is optimizing homeopathic decision making. So in this webinar series, we're going to talk about clinical case reports. Now, so for me, this is a bit of a personal journey because sort of my career, in my about 30 years career now, I started in practice, but then when I was in practice, I started asking questions and say, yes, I know, I can see in my practice, my own practice, that it works, but how can we get the message across better? What can we do to get more rigorous empirical data on what we're actually doing? So I sort of embarked on this journey to do, I studied epidemiology. I specialize in clinical epidemiology. So as you can imagine, the last months has been a bit crazy for me because as an epidemiologist, I've been kind of involved and dragged into a lot of COVID-related projects. And of course, this project is one very important one because it's really about the foundation. The clinical case report is the foundation, obviously, of all the other types of projects and data that we collect. But for me personally, I've sort of moved away from practice, I would say about maybe almost 20 years ago now already. And so I was really operating in this field. And since 8 years and since 12 years, I'm working on this topic of improving the quality of case reports. And this has enabled me to sort of to make a full circle, because I came to realize more and more as I sort of explored this topic about clinical case reports, that the clinical case report is, of course, closest to the daily practice of every homeopath or practitioner. And so to bring that science back into this domain sort of was, for me, closed a personal circle to really link it back to practice. But I also hope to bring you into that journey where you realize that you can bring science into your own practical work. Now, what's overall the vision? Why would we want to improve the quality of clinical case reports? In principle, we really hope to improve the reliability and value of homeopathic clinical case reports in general. And of course, we've seen now, Lefteris showed a few COVID cases, and we kind of sense that inside the first case was actually interesting because it was a more complicated case that received multiple homeopathic medicines. And the second case was very interesting because there was, after giving camphora, a very dramatic improvement as demonstrated by X-ray data in a very short time frame. And so these case reports, you just kind of have the feeling that we can learn a lot from that. But we can only learn really well from cases if they're really properly documented. And of course, the problem is now what we see is that often people, homeopaths between themselves, they submit some data and then they think, okay, that's more or less okay as it is. Maybe for discussions between homeopaths, that's okay. But if you really want to properly get your message across to a wider audience who really want to understand what you have done, we really need more granular information. We need more detailed information. So the whole idea is also that we need to promote transparent and accurate reporting. In other words, that you enable the reader of your case report to share in your thought process. So you make your thought process transparent. So you enable the reader to judge for him or herself in a way whether they agree with your experience and what they can learn from your experience as well. So it's really about sort of better teaching homeopathy. Obviously, if we're being taught homeopathy based on good quality cases, we can learn more. And of course, the overarching aim is how can we improve homeopathy? So it's not necessarily to prove homeopathy. For that, we may need other types of studies. The emphasis is really on how can we improve homeopathy. Now, case reports as such is nothing new. Actually, the first recorded case report dates from 1550 before Christ, so that's over 3,500 years ago. And if anybody reads hieroglyphs, maybe they can raise the hand and the person can translate. But for those who don't, I have looked at the translation. But basically, this was a description where if someone has a dislocated mandibula, it's a description what kind of manipulation you would do in order to reposition the mandibula in the correct place. And in fact, this is still a procedure that would be done. So in a way, it's still a valid case report in terms of what's described. So here, the key message here is that case reports are as old as mankind. From the moment people started writing in Mesopotamia, they started writing up case reports. And what we actually have to assume that before we started writing about 4,000 years ago, there were already case reports, but they were then passed from father to son, so there was more an oral tradition. But the case report as a story and sort of traditional medicine and the experiences of traditional medicine would have already been passed on as an oral tradition. So really, if you look at it from the point of view of evidence-based medicine, it all started with case reports. Now, so every case can teach us something. Now, so if we then go fast forward to the late 20th century, there was this very strong movement within medicine called evidence-based medicine. And one of the propagators of evidence-based medicine was David Sackett. And interestingly, he argued, and he very clearly stated that, yes, we need to have evidence, but we also need what he referred to as clinical expertise. And because he argued that clinical expertise will guide you into using the evidence in the care of the individual patient. So at the bottom here, I have summarized the holistic definition of evidence-based medicine, which is the conscientious, explicit, and judicious use of the current best evidence. Yes, so we need to know the evidence, but it should be focused ultimately in making decisions about the care of individual patients. And so there's two components to this definition. The first component is, yes, evidence. And the second component is really the context where the clinician will treat the individual patient. So the application of that evidence within the context of individual patients is the true spirit of evidence-based medicine and practice-based medicine, of course. Now, if we look at the late 20th century and we would say, what's evidence-based medicine? People would say, oh, that's randomized controlled trials, that's systematic reviews of randomized controlled trials. And if you would raise your hand and say, yeah, but clinical case reports are also part of evidence-based medicine, most people would sort of simply laugh you off. They would simply say, well, no, case reports, that's just anecdotal. And case reports are unreliable, it's anecdotal, and we really need clinical trials, placebo-controlled clinical trials, randomized controlled clinical trials, systematic reviews. And these systematic reviews, on the basis of that, we can just formulate practice guidelines, and then clinicians should apply simply these practice-based guidelines. And Sackett himself, he got actually a bit frustrated because he felt that something got lost, because he felt that there was too much focus on the actual use of only randomized controlled trials in clinical care. There was one other light in the darkness, and that was Milos Janacek. He was a Canadian professor of epidemiology, and he actually published in the 1990s, late 1980s, this book on clinical case reporting and evidence-based medicine. And this was really a milestone, because he was really one of the very few people in the field of epidemiology who said, look, we need to look systematically at the role of clinical case reports as part of the framework of evidence-based medicine. Now, Milos, he identified more or less 37 reasons for case reports in his book, and I've broken it down into sort of two main categories. One is for teaching purposes, and the second is for research purposes. In other words, for teaching purposes, you know, someone may want to show you what is a usual lycopodium case, but of course, it's also interesting to know what is an unusual case. Of course, there can also be failures, maybe when it did not work. So these teaching purposes, of course, we're all familiar with, because case reports in homeopathy are, of course, very, very widely used for teaching purposes, but less so research purposes. And for instance, one objective could be the generation of hypotheses, and another one would be validation and confirmation in clinical practice. For instance, Hahnemann himself, he started by his proving of China bark, and on the basis of that, he started compiling some sort of basic materia medica on the basis of proving data. But of course, he then developed his homeopathy further on the basis of clinical case material. So this process of using clinical case reports for research purposes and to validate and confirm cases is also something which is very familiar, and actually is the basis of homeopathy. So where are we actually? Now, if you look what's happening for the first decades of the 21st century, when I really started looking into this topic myself, it was clear that case reports were widely increasingly published, but surprisingly, there was no reporting guideline. Now, you may have heard about the Consort guideline for clinical trials, you may have heard about the PRISMA guideline for systematic reviews. So if you look at the stroke guideline, all kinds of guidelines were published as instructions for people who want to publish different types of research, but nothing for case reports. That's a paradox, because we've been doing it for 4,000 years. So it's kind of surprising in a way that there was no guideline, but it was also confirmation that in the late 20th century, case reports were really a bit pushed to the side and not considered and taken very seriously in evidence-based medicine. Now, so what happened? Only in 2013, the CARE guideline was published, which I will talk about briefly, and which is something which we'll also elaborate on in these webinars. And in 2016, specific items for case reports in homeopathy, which is referred to as the home case care extensions, were published. So these are relatively recent developments. So we have at the moment conceptually two aspects. We have the generic aspects that are applicable for all case reports, any case report, whether it's conventional medicine or homeopathy. So the generic aspects are reflected in the CARE guideline. And then there are discipline-specific guideline extensions. And the home case is one extension for homeopathic case reports. And another CARE guideline extension is, for instance, the SCARE guideline. And that's actually an extension for surgical case reports. And I think it's kind of ironical that they decided to use the acronym SCARE if you're going under the knife, that you're ultimately, your surgeon is going to use the SCARE guideline to maybe write up your case report. So this CARE guideline consists of a number of items, and ultimately these items are reflected in a checklist. And so we will work with this checklist in the course of this webinar. So at the moment, I just want to introduce you and familiarize you with the concepts. But basically, you can see that on the left here is this is basically the architecture of a case report, as Professor Miles Janicek would refer to. In other words, like the backbone, the skeleton. There's a title, there's keywords, there's an abstract, an introduction, there's patient information, there's a timeline, there's a diagnostic assessment, there's a therapy, then you assess outcomes, then you discuss, and you may want to bring in the patient perspective, ideally. So this is kind of the flow, sort of the backbone. And here in this checklist are more detailed descriptions of, you know, when you write the title, what should you think about? In terms of the abstract, what are elements that should be addressed? So this is fairly straightforward. This is not rocket science, I always say. It's fairly straightforward. Now, this is an example of a timeline, because the idea is, ideally, if you are having a case report that you want to share with your colleagues, people should really understand the chronology well. So this is an example, but the timeline doesn't have to be something fancy and graphic such as this. It can be a simple table, but at least with one column with the date, another column, what happened. And so you should be able to see what happened in the course of time. Now, my involvement was, as I mentioned, started about 12 years ago, and that resulted in sort of two key articles which I wrote. The first article was in 2015, where for the whole field of complementary medicine, I wanted to get the message across is that we need to improve the quality for case reports in the whole field of complementary medicine, and why do we need guidelines. So there's more the general framework. I wrote an editorial, and again, people who are interested in this, they can find these kinds of publications online about, you know, how can we separate the chaff from the wheat, and in terms of how can we optimally benefit from clinical case reports, and we need to be able to distinguish what is a good quality case report and what is a poor quality case report. So, and the third publication was the home case care, which was the supplement, the extension to the care clinical case report line, but in this case, an extension for homeopathic clinical case reports. Now, this was published in 2016, and basically we did a Delphi process, which is a well-established procedure, how you can gain a consensus amongst experts. I'm not going to go into the details of that, but the basically idea was that we started with a shopping list, as you can see here. It was a shopping list of about 30 items, and then gradually we started narrowing down that shopping list, and we've asked for the different items. How important do you think to these experts on a scale from 1 to 10 are these items, and ultimately the core items, which are listed in green here, they, as you can see, had a score of normally you would say 8 or up, 8 out of 10 or up, that everybody, the consensus was that everybody said this is really very important. And there was one borderline case where we had a 7.8, which is the occurrence of a homeopathic aggravation. And as you can see, for instance, in the comment, that everybody said, yes, it's very important, but except for 2 respondents, but some people said, yeah, it's important, but you can't really define it very well. It's hard to define. So that's why it went down a little bit in terms of importance. Now, what you can see here is green, gray, and green and gray. And so the green items ultimately went into the core items that we used for the home case care extension. But there are also some items that can be important, but not are always important. So in other words, if an item is not part of the core items, then it doesn't mean that it's not important at all. So for instance, your prescription strategy, or do you use totality of symptoms, do you use keynotes, essence, or whatever to motivate your prescription, was considered 7.6. Now, why didn't it go into the core? So this is very important for teaching purposes if you would use a case. But it's not, if you don't use the case for teaching purposes, then it might be too detailed to talk about this. So the fact that it's not part of the core items doesn't mean that it's not important. So what you can see here again is this care guideline. Everything in white is this care guideline. And what you can see here in green is what we inserted into the care guidelines as the extension for homeopathy. And so one core item is that we need to be clear about what were the homeopathic symptoms that effectively inform your decision, your remedy decision. And as you can see here, for the therapeutic intervention, what kind of medications was used, but also in detail, you know, what kind of potency, whether it was Hahnemannian or Korsakovian, trade names, whether it was tablets or drops, these kinds of details about the homeopathic intervention. And the third cluster is really related to follow-up and outcomes. And you can see here, for instance, objective evidence, we'll get back to that, occurrence of homeopathic aggravations, I refer to that, and possible causal attribution of changes is explicitly assessed. And we'll get back to that as well. So one of these elements, as I just mentioned, is the likelihood of the causal attribution. And the idea is that some criteria were developed for that. These criteria actually were developed in conventional medicine. They were subsequently modified for homeopathy. And I'm really pleased also that we are having Dr. Chetna Lamba as one of the panelists. And she is going to talk next week in much further detail, because she has been working for the last 4 to 5 years on the validation and the further improvements of this, this item checklist which is referred to as the modified Naranjo criteria, and she rebaptized it the monarch criteria. But now I just mentioned it, but we're going to skip. Okay, so that was the first part of my introduction. And the second part, I'll briefly talk about this topic of critical thinking. And I've already tried to explain or argue that critical thinking is not just important for researchers, but also for clinicians. Now, very briefly, what is critical thinking? It's the adoption of a constructively critical approach to beliefs and claims. And so what's very important is that word constructive here, because obviously being critical is what you call an ambiguous word. I mean, if you're critical if you're critical of your wife, then maybe she's not happy. So criticism is ambiguous. It can be constructive or it can be non-constructive. Now, to emphasize that obviously critical thinking in the context here is always being critical with the aim of being constructive. Now, why is critical thinking so important in case report? And so that this awareness grew in me when I started reading more also about human decision making. Obviously, as an epidemiologist, I also knew there were biases in decision making. But the more I read, the more I realized that, yes, this critical thinking needs to be linked to this topic of clinical case reports. And one sort of key thing which I really want you to remember is that evolution has hardwired our brains to look for causality even when there's none. Now, so we're trying to make sense of the world around us, and we're trying to explain the world around us. But our brain actually will try to explain whatever happens to us, and we'll look for causality even if there's none. Now, why is that hardwired into our brains? It's because when you make false positive decisions that offered survival advantages, and I always use the example, by the time we were still hunter-gatherers, if you would see a tiger, if you would have high grass and there would be a tiger and you would see some stripes, you would think you would see some stripes between high grass, and you think, oh, that could be a tiger, I better start running. In other words, you assume the causality that there's a tiger there in the grass, you start running, but you may be wrong in many cases, so you stop running, but you're alive. Now, obviously, it was a false positive, but that was not so bad. Now, let's turn the situation around, that you're saying, yeah, there is, I see some stripes, I think I'm seeing some stripes, but actually it's only a 30% chance that there is, that it's a tiger, so no, I don't think it's necessary to start running. Now, we could definitely understand that the person who would act like that would have less survived less effectively. So the person who makes false negative decisions is not really surviving as well as the person who's making false positive decisions. So this is really a core aspect also for case reports, because we will sometimes also look for causality in cases when they're in terms of thinking that it's a remedy response, where in fact we have to be quite more careful about that. So this critical thinking is so important because we can only promote practice-based medicine if practitioners lack an understanding why it is important to apply research into your practice, and why actually critical thinking is important to improve the care of your patients, to improve your individual patient care. And of course, I always use the example is that Hahnemann was actually a critical thinker. If he would have uncritically adopted that the explanation, the sort of the rational explanation why China bark actually was effective for malaria, and he wouldn't have been a critical thinker if he wouldn't have doubted that explanation, then he would have never discovered homeopathy. So we're all, if we want to be homeopaths, if we want to stand on Hahnemann's shoulders, we have actually moral imperative to be critical thinkers. So the core aspect in science and in research is this word bias. And you'll hear that in different guises, but a bias is any kind of distortion of reality brought by the design, selection, observation, classification, analysis, or interpretation of results. Now, that's a mouthful. You don't have to remember all of that, but basically, just remember the fact that it's a distortion of reality. So if there's some true value, then bias means you don't capture the true value. You distort the truth. So your observation, your conclusion is actually off the truth. And so bias is not the same as error. For instance, error is non-systematic. So if I would, for instance, measure someone's blood pressure, then, and someone sits a bit, someone is a bit lower, I squeeze it a bit harder, then there will be some variation in my blood pressure measurement. But if I do it 100 times, then you would get some sort of distribution, and the average of this distribution would be the true level for the systolic and the diastolic blood pressure. Bias is systematic. So in other words, if I make a wrong observation, I can repeat that observation 10 times, yeah, but it will still be wrong 10 times. So I am systematically making a mistake. So what are the kind of biases that can affect clinical case reports? And when I started studying this topic, and I studied some publications of Midas Janicek, and I started doing some counting. And depending on how you define biases, there are about 29 types of biases that can be applicable to case reports. So here is also the crux. On the one hand, we're saying, yes, there is an important role for case reports within evidence-based medicine, but the people who say, well, case reports are anecdotal, case reports, we have to be quite careful by drawing causal conclusions on the basis of case reports. This person is right, because biases can affect the conclusions that we draw on the basis of case reports. If you break these biases down, there's 4 main categories. And one is decision-making and behavioral biases. There are biases in probability and belief, social biases, and memory errors. So again, this is just to give you a flavor of, to make you aware that biases can affect clinical case reports. Now, I'm just going to give a few examples of, in this case, cognitive illusions or cognitive biases. Now, the classical one is anybody who studies epidemiology will say, okay, there are more storks in rural areas compared to urban areas. Families in rural areas are on average larger than families in urban areas. So, therefore, the following might be true. It may be that the storks actually bring the babies. If there's larger families, there's more storks. Or not. Now, in this case, obviously, we would know it's not. But what's happening here is that there is a correlation. Yes, there is a correlation between the number of storks and the size of families. But the fact that certain data are correlated doesn't necessarily mean that it is one thing causes the other. So you would be surprised, because this is now a bit of an extreme example, but you would be surprised how often people in the press, journalists, politicians, would, on the basis of correlations, imply that there are certain causal relationships. Now, the second one, so that's a bias, if we were to say that. So we reach a false conclusion. The other one is regression to the mean. Again, I'm not going to go deep, but regression to the mean has been described as the physician's best friend. And this is a general phenomenon that will always occur when correlations between two measures are less than perfect. Now, don't worry if you don't understand but just imagine that a doctor, when a patient visits a doctor, the patient has a certain health status. Now, what we would know that the health status of a patient is influenced by many factors. So it could be whether he has slept well, it could be whether he is smoking, it could be whether he was exposed to COVID during some sort of social event. It could be, so there's all kinds of variables that influence the health status of a patient. Now, but we also know that anything that is influenced by many factors, there will be a fluctuation. It will go up and it will go down. And regression to the mean says that something that will go up will also go down. There is simply a natural fluctuation in these kinds of phenomena. Now, when a patient is visiting a doctor, the patient is more, in terms of, if you go up and down in terms of health state, and when you have more symptoms, you have less symptoms, more symptoms, you have less symptoms. A patient is more likely to be in the surgery of a doctor when he has more symptoms, because he has more symptoms, he has some pain, he has some health issue that's really bugging him, so that's why he's going to the doctor. So, but within that natural fluctuation, the patient is likely to be on one of those peaks. So this is just a statistical phenomenon. So theoretically, many patients will get better, even if you have done nothing, you have prescribed no remedy, you haven't smiled at the patient. Even if the patient would have just entered your clinic, he wouldn't even have seen you and the patient would have gone home again, many patients will get better. So this is regression to the mean. Now, what you have to remember is that this is very counterintuitive, because we tend to think, okay, a patient comes into my clinic, I prescribe something, and the patient comes back and thinks, and we tend to think, oh, great, that's good news. And so we tend to think, oh, this improvement might be or is probably due to the homeopathic medicine. Now, again, I remind you, our brain is hardwired to look for causality, even if there is none. So some of the improvement that we will see is not caused by anything. It's simply regression to the mean. So that's why it's very counterintuitive, because we think, oh, it's caused. The improvement is caused by something. And actually, not all the improvement is caused by anything. It's simply a natural phenomenon, a statistical phenomenon. Now, very briefly, we have two types of thought processes. Our human brain is a dual processing system. One is an intuitive, a fast heuristic. Well, heuristic is a difficult word, but heuristic is simply a rule of thumb that we apply. It's associative and high context sensitive. And most of what is taking place in this intuitive system is where we are not, we have little or no conscious control. I mean, some people would argue your intuition, your clinical judgment is completely unconscious. And some people will argue, no, you can still have some sense of your intuitions. But overall, you have little control. And the second system is the analytical, slow, systematic thinking, low context sensitive, but we have a high level of conscious control. Now, so if we look here at the care of, if we said evidence-based medicine and we talk about the best evidence, usually we're talking about evidence that has been generated by this slow scientific analysis and thinking, you know. But when we're talking about applying the best evidence in the context of the care of our individual patient treatment, we will use often this intuitive or heuristic approaches. We will use rules of thumb, and we will apply our knowledge, you know, within the highly specific context of the treatment of our individual patients. Now, what's needed is both systems. We need system one, which has from an evolutionary point of view been very effective, but we also need system two to sometimes override system one when sometimes this intuitive system can jump to the wrong conclusions. Now, why is this important? So I just want you to have a very quick look at the next picture and tell me, what is your first impression about the length of the soldiers? Whether are all three soldiers equally long? So just think for a brief moment. Don't overthink it, but just think, what was your first impression when you looked at this picture? Now, most people would answer, my first impression was that this soldier here on the right-hand side was taller than the soldier on the left-hand side. And that's actually wrong. All three soldiers are, it's a biased conclusion. Now, why is our conclusion biased? Just to come back to this fast system here, it says it's high context sensitive. And so our fast system here looks at the context of the perspective. And our brain is working in 3 dimensions. So we actually consider this, we process this within the context of a 3-dimensional system. But actually, it's only a drawing in 2 dimensions. And so if you would put a ruler in 2 dimensions on these soldiers, they would be equally long or equally tall. But our system, our brain, cannot resist looking at this in context. And that's a good thing, yeah? Because when you treat your patients individually, you apply things in context. So that's great. But take home message, it can also lead to biased conclusions. Now we're going to do one little experiment, and it's about the anchoring effect. Question 1. Was Gandhi more or less than 144 years old when he died? So just think for a brief moment what you think about the answer to that question. Question 2. How old was Gandhi when he died? Now, so you could even write this down for yourself. So now what I would like to ask you is, do you think this is this question? Is this question useful? In other words, were you less than 100% sure about the answer to this question? Now, obviously people will know that 99.99% of people will say, yes, I'm 100% sure Gandhi was less than 144 years old. So in a way, this question is uninformative. It's not, it doesn't really, I haven't learned anything from this question. So my question to you now is that did the answer to this question have any influence, from rationally speaking, on the answer you would normally give on this question 2? Now, actually, the outcome is they've done this experimentally with a lot of people. And they asked this question 2 alone, yeah, or they asked this question 2 preceded by this question. And if question 2 was preceded by this first question, the age was about 50% higher on average than when it was asked in isolation. So what's happening here? This is called an anchoring effect. In other words, there was question 1 anchored. It's triggered certain associations. We know, of course, that Gandhi was less than 144 years old, but we are thinking about old people. We are thinking about very old things. And so our brain was actually unconsciously activated old, association old, you know? And so then when our brain is primed by that, and we ask how old Gandhi was when I died, that priming of our brain, this anchoring, actually influenced our estimate of Gandhi's age. Now, what's the conclusion? We can be biased in our judgment by our environment, including by random or totally unrelated factors. So, take-home message, we can be influenced in our conclusions by totally random factors and by non-random factors. So the main lesson is, don't think that, as Hahnemann of course said, we should try to be, in his organon, that we should try to be an unprejudiced observer. Yes, we should, but remember that we are all more influenced than we think, and we are all biased to a certain extent. It's hard to avoid because some of this is unconscious. So just to round up now, because I'm looking at the clock, I'm just going to round it up, my presentation, to give some time for some questions. Why does all this affect case reports? Now, clinical case reports are stories. And we all know we love stories because we've been doing that for 4,000 years. But our intuitive and fast-thinking processes are biased toward creating a coherent story. Again, our brain is looking for causality. We try to make sense of our environment and we just fill the gaps because that makes us feel more relaxed and less fearful because we think we understand the world we live in. But we have to realize that our brain completely ignores the amount of data and the quality of the data, especially if we don't take time to think slowly. So in this fast thinking, we largely ignore this information. So what can we do to remedy biases in case reports? We need to incorporate what I would call a negative test strategy. So, for instance, when you treat your patients and you see a change, just for a brief moment, do a thought experiment and say, well, the observed changes in my patients are not due. If I just assume for a moment that the changes in the patient are not due to the homeopathic remedy I just prescribed, could something else explain the observed improvement? The other thing is that we need to do is that we need to create an information-rich environment. Because, again, our brain will fill the gaps because we try to make a nice story. Like, for instance, each homeopath will try to make a nice story about the simillimum. He hopes at the end of every consultation to come up with this feeling, yeah, I'm confident, I've got the simillimum, I really got the matching remedy. So we have this desire to come up with this story that we have actually found the simillimum. So we also need to look for information that we don't have. And the reporting guideline can help you because it gives a certain structure. And ideally, we should also generate as much as possible independent observations. Another objective data is some sort of cross-validation of my own observation in a more objective way, or by another observer, or by some sort of lab test. So we can create an information-rich environment for case reports by using clinical case reporting guidelines. when writing up case reports, because it imposes the structure. It imposes some of the bias reduction strategies which I refer to. And so now, just to conclude, what's the outlook and what are the next steps? We need to deepen our understanding of what I would refer to the qualitative aspect of treating COVID-19 patients. And this is very important because at the moment, worldwide, there are several projects going on in the United States, in Asia, in Hong Kong, and there is already a fair amount of quantitative data. I think we are now already in a position, for instance, Lex Rutten is analyzing about 200 cases, and he's looking systematically based on successful cases, which remedies were prescribed, which symptoms were used as part of the individualization of these remedies, which symptoms seem to be quite useful as prognostic indicators for different remedies. So we are already accumulating a fair amount of quantitative data, but ultimately this quantitative data is derived from clinical case materials. And so we need also this qualitative perspective. And we also need what I refer to as scratching under the skin of the data. And in science, it's quite well known that you're saying quantitative data is not everything. It's very important. You need to have a feeling for your data, what's underneath your data. So we need to see some really granular case reports of COVID patients that were treated. And that will give us this, as the Germans say, the Fingerspitzengefühl. In other words, it gives you the sensation in your fingertips. And this is really goes again into this aspect of the looking at the context of cases. And this context is important for practice-based medicine, because ultimately we need to apply the knowledge, what's in the Mater Medicas and what's in the laboratories. We need to apply that in the context of individual patients. So I always say that writing a high quality case report is very easy. It's not rocket science. And I've been doing sort of giving seminars now for like this webinar series, workshops and things like that. And I'm always surprised because I give a lecture similar to this one, sometimes a little bit more detailed, a little bit longer, but basically what I've shared with you now. And then we're saying, okay, right, let's do a practical exercise. We're going to review a case. And you give people the checklist. We're going to say, look at the case report, people analyzed in small groups. And I'm always surprised how people are able to dissect and analyze the case reports, apply these guidelines and say, yes, that was a good, but that information was missing. So it's not rocket science. It's something you can apply very quickly. But of course, as we all know, it's much more easy to critically analyze someone else's case report than to write one up yourself. And so that's why you were faced with the paradox that it's also hard to write up a case report because it requires this structured thinking. It requires not just quick thinking and say, well, what were my roughly very quick description of the case? No, it requires this structured, slow thinking process. And it's surprisingly hard when you have to do it yourself. And it requires discipline. So to conclude, high quality clinical case reports are an integral and important part of homeopathy's evidence-based. Critical thinking in conjunction with reporting guidelines are essential for improving the quality of clinical case reports. And we have now, for the last 2 weeks, launched this clinical case report project. In other words, really detailed clinical case report project. But so far, the quality was relatively poor. And so we need more high quality COVID-19 clinical case reports urgently. And so this is also one of the reasons why we decided to give this webinar series to give you all more confidence and to give you all more motivation to write up your case reports, and if necessary also to give you support. Thank you very much. And that's basically the main thing what I wanted to share now. And so there is some time for questions.
Thank you, Robert, very much. It is for this very interesting presentation. It is very interesting to hear that we are all biased and we need to address these biases. I want to emphasize to the part that you said that every case can teach us something. Even the cases that with no good answer, with no positive effect, even those can teach us a lot. And what we want is cases in order to have cases to draw conclusions. It's not rocket science, like you said. It's not. Of course, we have to elevate the quality of our case reports, and we have to learn from you. But even if it is not so high the quality yet, we need those cases. We need those cases in order to see about this theme now, about the COVID-19, to see which symptoms from the homeopathic point of view are more frequent in this disease, which remedies are more frequently prescribed, and see also some other aspects of the disease. Apart in this effort, we are together with the LMHI. We are going to send these cases to a panel of the LINCA, to a central database that there will collect all the cases from different points in order to have more conclusions. So very interesting presentation. Thank you for this. We have some questions. They ask if you are going to, if your presentation will be available. Petra asks.
So yeah, I think the idea is that this whole webinar is recorded, and it will be posted on YouTube. So for those who want to look again at the presentation or want to recommend it to a colleague, I think, Lefteris, you're going to post it online?
Yes, we are going to post it online, and people can see it again, or like you said, send it to a friend, to a colleague in order to see it. Yes, we are going to do this as it is recorded. Other questions that we have? Is there any other question for you?
Yeah, let me just see. Yeah, I think this is an interesting question. I'm sharing it now. I think everybody can see it. It's a very relevant one, I think. It says, intuitive prescription was easy in earlier days, but with ever increasing symptomatologies of our materia medica of new drugs, the situation is just opposite. Thus, we are taking help of repertories more than earlier. What is the opinion of Dr. Robbert in regard to intuitive prescription is gradually losing its own importance? And this is actually a very important topic, because this is why I briefly touched on my introduction on that we have these two modes of thinking. We have the fast thinking and the slow thinking. And sort of your clinical experience is fed by having seen a lot of cases. And so every homeopath with growing experience, he will see a lot of cases. And if you have seen similar situations, then you can become slightly more intuitive, because you can be quicker in terms of, you can apply a heuristic to more quickly come to the medicine. But even someone like VithoulkasCompass, with George Vithoulkas, he would argue these intuitions, they can be wrong and they can be biased. So sometimes you always still need to check the actual information. So intuitive prescription was easier in earlier days. That was only because you used less information. The issue is that it's not about using less information. Ideally, you want to use all the available information that's in the repertories and in Complementary Medica. And that information you want to use to get in your repertorization and ultimately in your decision making. And your decision making will be a mixture of your clinical experience, but also your slow thinking, where you may need to debias your decision. But you know, it's a big question. It's a big topic. Just a week ago, for the Central Council Research, I gave a 1.5 hour lecture just about this topic. What's the role of your intuition in your decision making? But your intuition is relevant, but you need both your intuition and your slow thinking.
Thank you very much, Robert. We have some other questions, I think mostly for me. Tima, I think if I pronounce correct the name, writes, there is no camphora 1M, 10M, only camphora 200. What should I do? Because this specific case was prescribed camphora, it does not mean that camphora is the most used remedy, in no means, or any other potency would not act. In fact, we don't have much cases now, but from the cases that we have, camphora is not among the first remedies, but bryonia, arsenicum, and phosphorus were the first remedies until now. But as I said, we need more cases in order to draw conclusions about the most frequent prescribed remedies.
All right,
another question about from Petra. She asked, did the patient one take any conventional medication? How did the case go on? Let me share my screen. Okay, this is a case one. This patient did not take any other medication apart from an Imodium he took the last day that did not help for the diarrheas. And then the diarrhea solved the sulfur solved the case and the diarrheas. And you ask also about the repertorization. Now, the repertorization in this, let me briefly say why each remedy was given of this. The first remedy that acted was Lycopodium because mainly of the rubbing and the distension. Okay, the second remedy that acted was Ipecacuanha. I repeat that the first remedy was arsenicum that did not act. Then we had Lycopodium because mainly of the rubbing. Ipecacuanha because mainly of the intense nausea. Then we had China again because of the distension, and sulfur solved the case and was prescribed because of this offensive diarrhea that continued after this acute.
Yeah, I think what we're seeing so far in COVID also, because the there's always this discussion about genus epidemicus. And of course, it all started with Hahnemann in 1799 giving belladonna for scarlet fever. And so there's been a lot of discussion about, well, is there a genus epidemicus for a medicine for COVID-19? And what we are learning so far is that there doesn't appear to be a single
correct.
Medicine. I mean, Bryonia and Arsenicum album and Gelsemen appear to be relatively frequently prescribed, but many other
Still, we
remedies
don't have cases. Yes, we have a variety of symptoms and of remedies, so we cannot spot to a remedy or a group of remedies. Correct.
So this is interesting because and actually the information is even that maybe in different regions of the world, even there can be different. Now, the only way in which we can learn from this is by systematically collecting our experiences. That is the only way in which we can quickly gather that information. And we are now, I think, one of the first times in history that the whole homeopathic community is working together to collect this and gather this information. And in this case, for the coronavirus, we are learning that it seems to be a more complicated kind of acute disease, which has many different types of expressions and may not even, in most cases, need only one remedy. But again, this is why we need to learn from our experience.
Yes, thank you, Robert. Another question says if there were cases in LM potencies. No, we don't have any cases in LM potencies yet. And the repertorization of the second case is this, because someone asked this question, you can see it. And now I want to show you how you can send your cases, because we said that we need cases to collect a database of cases. What you can do is within the program, there is this template, LMHI COVID-19 clinical case report submission form. I think, Robert, you can explain this in the next webinar. This is a template that will guide you through a proper case report in order to have it. So you fill this form here in the case notes, and then you go here on the case, go send, and you're going to send it to LMHI 2020. LMHI 2020, it's this user, and click send. So now it writes you cannot send it to yourself because I'm in this account, but you go on the case, click send, right here LMHI 2020, and send the case, and then we will get the case. For those who don't have an account, they can open a free account and go here in the main, my cases, my account, purchase, and those who don't have active subscription, right here, COVID-19, apply coupon, and with this coupon, you'll have 1 month free. Those who want to send us cases, please use this coupon, get the one month free, and send us the case. Also, if you don't want to send it from VC, you are also free to do it. You can go to VithoulkasCompass.com and download this form, VithoulkasCompass.com, LMHI 2020. You go here, COVID-19, download this form, and let me show you this form now. Stop share and share the form. You see, it's this form here, again the same, and it writes here an email, lmhi2020@vithoulkascompass.com, and you can fill the form and send us the form in this email. Also, in this email, we will be happy to have your comments regarding this webinar, and what you would like us to emphasize more, what you would like us to improve. Okay, let us see if we have any more questions.
I think it would be good to do a Regina Leborg, because it's about, she's asking, can you provide the screen with a care guideline list for us to download? So I think, so this is what you just explained, of course. I think it might be useful as well to send people the checklist.
Yes, okay.
What we will do is sort of this home case, this checklist which I showed, which gives you a very sort of a high level overview. I think that might be useful for people also that they have that checklist, because they may want to apply that checklist to other case reports or even to their own case reports before they submit, to double check, okay, is everything in there? That checklist can be a helpful tool. And so all the people who have registered, we will send that checklist.
Okay. What else? The next webinar will be in 1 week from now. In this next webinar, Robert will elaborate more in this care guide home guidelines. Dr. Chetna Lamba will explain more about the monarch criteria. Chetna, are you with us?
Yes, I'm there, sir.
Okay, you would like to explain for 1 minute what you are going to tell us in the next webinar?
Yeah, it will basically be the validation, elaboration, and history of monarch. What was the methodology we adopted for validating it, and what is the final outcome? And basically, it is a very useful tool for establishing the causal attribution, because case reports, they are considered the weakest level of evidence. And in case we apply this monarch, we can ascertain that there is a good causality between the intervention and the outcome. I'll elaborate in subsequent webinar. Thank you.
Thank you very much, Chetna. In the next webinar also, Irini, which is an IAH graduate and a member of the team, will present one case. And let me see if we have any more questions. Petra writes, I think we need at least 40 days from the last symptom of follow-up of COVID-19 cases. Okay, we have this because some time has passed after the prescription of the sulfur case in the first sulfur remedy in the first case and the camphor in the second case. We have this although we did not write. This is a correct, I think, comment. What do you think, Robert?
Yeah.
Do we need some so many days for the acute, or we need less?
I think it's hard to put a very fixed number on it, but I think it is quite clear that you would want to have a follow-up that would permit you to be confident that it couldn't have been, you know, that you might have cut it off too soon and there could have been a relapse. So I think, yeah, to be more confident, you really want to know, okay, this is really the end of the acute cycle. But the problem is that what you can see with some COVID cases, you hear that sometimes people can have for more than 2 weeks certain sequelae such as anosmia or such as tiredness or it seems that there can be sequelae to COVID-19 that can be almost like semi-chronic in some patients. So in those cases, you would actually need even longer than 14 days follow-up.
Yes, yes. There is one question. Dr. Vaishali Shinde asked you, Robert, to comment on the quality of the second case. The second case was the case that we don't have a confirmed COVID test, but we have this reported positive effect after the remedy, and we have also this chest X-ray which showed improvement.
Yeah, and I mean the reason why we in a way wanted to show this second case is because when you see it, you get that sense. Wow, this was a dramatic case because there's really objective changes relatively after a very short period. This is what you would say, yeah, that would convince me. But the reason why we showed it also is that we got a very brief information. And so if we would apply the home case care checklist to this report, our conclusion would be it's a very, very poor quality case report. Not because we have the feeling this is not potentially a not interesting case, but it's poor quality because we're lacking a lot of detail. We need,
yes.
And so this is in a way what should inspire us, because yeah, if we can demonstrate more, can make this more convincing, then even though it's not our primary objective to convince others, if we can develop a narrative around homeopathic COVID cases, and they are very properly written up cases, then even other people might think, okay, you know, this case doesn't prove that homeopathy is efficacious for COVID-19, but I find it convincing, you know. So even then we can make more impact with persons who are open-minded, critical but open-minded, because they know rigor has gone into the case report. And so it's about all this potential that is untapped, that will remain untapped if we don't have the discipline and we don't have the skills to write it up in sufficient detail.
Yes, thank you. An anonymous attendee asked why you need cases. You belong from Europe, which is most affected by COVID-19. What you have done over there at ground level, what we have done. It is strange because people think outside that we are in Europe and people outside all have COVID, are COVID-19 positive. But in fact, it is difficult to get access to cases because if the case is positive, it goes to the hospital, and it is difficult to get access to it. And like the case that we have, the individual has to deny therapy or the conventional therapy, or in additional to the conventional therapy, take the COVID, take homeopathy. So it's not, although it seems easy with so many cases, and it should be easy. In my perspective, I was expected from the medical authorities to give us ground to treat COVID patients, but the truth is this is not the truth, and we in fact having difficult time to find patients in order to show the evidence of homeopathy. And Vithoulkas also in the video that we show proposes this model of research that can be more easily accepted by the authorities, like the one group taking conventional medicine and the other conventional plus homeopathy, in order to be more easily accepted. But even this model, we as the Greek Medical Association, we propose this model to the medical establishment, but yet the they denied us the access to the hospitals.
Yeah.
So from every country, if you have cases, even suspected cases, can be of value to us, and you can send us. I repeat the way that you can send us. The one is through VithoulkasCompass in the account LMHI 2020, or by downloading the template and sending it to LMHI 2020 at VithoulkasCompass.com. Any other question?
Just Lefteris, I think if we are not able to answer all the questions for lack of time, then we will save the different questions, and we will still try to address some of the questions then next week if we're, because
Okay.
we're running a little bit. But so if your question question has been answered, we will download it, and then if necessary, then we will still try to answer your question in the course of the webinar series.
Okay. I think that's it for the first webinar. Thank you very much. Thank you again, Robert, for this very interesting presentation. We are looking forward to hear you also in the next webinars, and Dr. Chetna Lamba as well. And thank you everyone for being with us today, and we are looking forward to see you again. Let us meet again in 1 week from now, the same time.